We can start.
Okay. My sister Yang, you are welcome. Thank you for your kindness.
I was
You
virtually
know, well,
arrested
uh,
by you
well,
know
that's good.
who.
No, that's what friendship is all about. You can make a demand. You knock on the door and
Virtually
I,
arrested.
yeah, you can knock on that and say, "Well, I have somebody that needs bread at 12 midnight." You have to respond. Well, welcome everyone to this platform. As you are aware, we have this program once every month, and today happens to be a webinar day for May, and we have a wonderful presentation. I remember when I was writing part one many years ago. There's a short note about what do you call people who are stubborn in Africa and all that, and that's the way we need to look at this people. That they are very stubborn. They do their thing of their own and all that. But I think knowledge has increased, and I'm sure our team lead is here to educate us. And so I'll yield to Dr. Letu. But before I yield, just to encourage that, please mute our mic. And if you have any question during the course of this webinar, you can use the chat box. And along the line, also during Q&A, you'll be allowed to unmute and ask questions. So over to you, Dr. Letu, our president. Thank you.
Okay. Good afternoon, all, and welcome to our May 2026 webinar. First, I want to say congratulations to our Muslim brothers and sisters, as today is still a public holiday as they celebrate Eid al-Kabir. Also, to congratulate all the Arsenal fans in the house. After waiting for 22 years, we celebrate with you. I also want to thank our seniors in the house, Dr. Mubalaji Lawal, Dr. Professor Abiodun, and I'm sure others will join us along the way. So today, we're looking at a topic called ADH in Nigerian children. We're looking at recognition, assessment, and management in resource-limited settings. Just like Dr. Dushote said earlier, we tend to see these children and we think, oh, they are just stubborn. And sometimes they are being beaten just for not adhering to what we want them to do. But now we know that it's much more than just being stubborn. This is a neurodevelopmental issue that seems to be we're diagnosing more and more now. And therefore, we decided that we should have this presentation. So today we have one of the members in the house who's going to talk to us. She's resident in the UK, but she's with us at heart in Lagos, Nigeria, having trained in youth. So without much ado, I hand over to Dr. Odushote to carry on with the proceedings. Over to you.
Thank you very much, Dr. Letu. The only thing you didn't mention that is she was baked in Ibadan and came to Lagos to earn her skill to be a businesswoman before going to UK. To moderate this session is a very dear friend of mine, a junior colleague, and at a very short notice, she obliged to moderate this session. She's also in that space, but I'm not sure she's still convinced that she should stay in that space. But I'm sure after today, I'll have a concern with her. So over to you, Dr. Afiomo, to please moderate this session. Thank you.
Thank you, Dr. Dushote, for inviting me to moderate this session today. It's a great honor. And I greet all our senior colleagues, the president, Dr. Ileto. Thank you so much for having me. I'll just do a brief bio for Dr. Takon, who is giving us the talk this afternoon. So Dr. Ian Takon is a consultant pediatrician who is specialized in neurodevelopmental disorders. She has over 2 decades of clinical experience that has been dedicated to improving the outcomes for children and families. Her career began in Nigeria, as Dr. Dushote has earlier mentioned, where she trained and practiced before relocating to the United Kingdom in 1997 to pursue further specialist training in pediatrics, epilepsy, and neurodevelopmental disorders. She holds master's degree in public health from Lagos, community pediatrics from UCL, clinical neuropsychiatry from the University of Birmingham. She also holds postgraduate certificate qualification in medical education. So you see, she is very versed in this topic, and it's a delight to have her with us today. Since 2004, she has served as a consultant at the Queen Elizabeth II Hospital, East and North Hertfordshire NHS Trust, where she conducts assessments and management for children with a wide range of neurodevelopmental conditions, including ADHD, that's attention deficit hyperactivity disorder, which we'll be discussing this afternoon, autism spectrum disorder, tic disorder, epilepsy, and fetal alcohol disorders. She led the ADHD service in her trust from 2004 till 2019. Dr. Takan is a mental health liaison lead in her trust and educational supervisor to trainees in pediatrics and psychiatry. So she strides between pediatrics and psychiatry here. She also contributes nationally through her work with the Royal College of Pediatrics and Child Health, serving on the Specialist Advisory Committee as quality and training advisor for the Child Mental Health subspecialty. She's also the lead for the Special Interest Training module, that's the SPIN, in child mental health. She's passionate about early identification and intervention. Dr. Tarkan is committed to bridging the gaps in care, particularly for underserved and diverse populations. She's the host of the Early Intervention Matters podcast, and you can find that at www.drtarkon.com, and co-founder of School Doctor, which is an innovative developmental service that connects schools, families, and healthcare systems to better support children's needs. And you can find that at www.school-doctor.com. Ladies and gentlemen, let's welcome Dr. Takon as she gives us her talk this afternoon. Thank you.
Thank you very much, Dr. Fimo, for reading that. Thank you. Yeah. And thank you, everyone, for inviting me. And a special thanks to Dr. Leto, who I said, and Dr. Dushote, who I said virtually arrested me. I wasn't planning to do a talk for a while, but it's lovely to be amongst friends and colleagues. I can recognize lots of names, my seniors. I can recognize quite a lot of people on the platform, and there are many I've heard of, I haven't seen. But thank you for all the great work you're doing, continuing to champion child health care in Nigeria. And even with all the limitations, there's such great work going on in Nigeria. So why did I choose this topic? Sorry, Tunde, do you want, is the slide coming on?
You can share from your hand, but that would be fine.
Okay,
But if you want to share from you, that'll be okay.
let me just, sorry. I think this is, I thought you were good. Can you see my slide?
Yes, we can.
We can.
Can you?
Yes, we can.
Put on slideshow.
Okay. No, I think that's the wrong one. Sorry, let me just just tell me if this is the right slide that's showing. Is it the right one?
Yes.
ADHD in Nigerian children.
Yes.
Okay. All right.
Just put in slideshow. That would be good.
Yep.
Okay.
Is it okay now?
Yes. Perfect.
Okay. So thank you, everyone. So I was a trainee in Louth between 1992 to 1997. Following that, I went and did public health, master's in public health before coming to the UK. So I reflected on my journey and my time there, which I learned so much. I know I keep saying that my training in Nigeria provided a bedrock for everything that I'm doing today because I learned a lot, and those skills have continued with me till date. And I remember my neonatal postings. I remember having to nurse many children, to look after many children with birth asphyxia, jaundice, prematurity, and lots of children in the neonatal unit. And then we used to have a follow-up clinic when we'll see them after they've been discharged for the ones that, were discharged and coming to the hospital. There were things that stuck to my mind was there were some children that came to the clinic and I would see them. They would be very disinhibited, very active. Parents would be struggling to control them or manage them because the child will be, I still have those memories. Some children trying to escape from the windows in the outpatient, and the mothers just tying them down and using their legs to wrap around them and hold them. Um, and sometimes staff screaming at the mothers to hold the children properly, the mothers smacking the children who didn't understand what was going on. So I saw that, and it didn't mean anything. I just used to wonder. I thought, okay, maybe it's just because of, what they've gone through, but never did I really connect it to the long-term outcomes of neurodevelopmental conditions. So obviously, when I came to the UK, I came to do a master's in community pediatrics, which had a lot of neurodevelopmental conditions there. And that was when my mind started opening up that actually we are seeing there, those children immediately came to my mind as I learned more, it immediately came to my mind, and I took an interest, more interest in this area. Along my work of doing, neurological postings, doing neurology at Great Ormond Street, I had the opportunity to work with the specialists who were seeing children with these neurodevelopmental conditions. And that was where it went full circle for me that actually a lot of the children we were seeing coming out from those early years, the long-term neurodevelopmental outcome, which we didn't have the opportunity to follow up, were some of the children we were seeing later. And some of those things, which we didn't recognize what they were things that actually we needed to follow up. So it's just, the why I took an interest in this. Secondly, I've had over my time here families contact me from Nigeria where things were breaking down. These were families from high socioeconomic group. They could afford anything they wanted for the child.
Right.
But it was, sorry, can you hear me?
You are
Can you
loud
hear?
and clear.
Okay.
Yeah, loud and clear.
So, all right. But it was difficult, and they had these difficulties and couldn't understand what was going on. Some of them were able to travel down to the UK, and we were able to do some assessments and found out that, some of them had neurodevelopmental conditions, some ADHD, some ASD. And some of these families were at crisis points. They had taken their children to different places, they had changed schools. The children had also suffered a lot of trauma from how they were being treated at the schools, being beaten by the teachers, being, stigmatized. So it is a huge problem, and increasingly so, just to let us know that the burden of the problem is huge. And unfortunately, the resources to carry out this assessment have not matched the increasing burden that we are seeing. So that's that's kind of forming the preamble of my talk. So to go on, just to say that this is completely independent, not being sponsored. I'm going to mention some of the guidelines. We don't have a national guideline in Nigeria, but the standards are basically the same. And it's a challenge to us in Nigeria that I'm throwing to us as pediatricians to look into developing our own, resources for assessing our children. Yes, there are lots of materials out there, but they don't do justice to our children in Nigeria. And so we need to think about adapting resources to the local context. So I'm hoping that this lecture gives us an opportunity to look at what are the core diagnostic features of ADHD, because many more pediatricians should be involved in assessing and diagnosing. How do we conduct a structured assessment, and what do we do in terms of management of the condition? So let's take our first child, Chidi, an example where he's come to your Lagos clinic. Sorry, I'm just going. He's come to your outpatient clinic. His class just sent 3 letters this term saying he's very disruptive, can't sit still, can't complete his work. And I'm not sure whether that's still happening a lot, but we know that the first thing that's resorted to in many of the schools used to be, I mean, when I was there, I hope it's changed, that children are not being caned repeatedly. And so you can imagine the frustration when those letters come home. Parents get upset with the child, and sometimes parents disagree on what is actually happening with the child. So, as you can see from this, the 2 parents, father feels there's something wrong, mother feels he's just stubborn. So let's take a look at this. Let's think about this. Do we think this child, this 8-year-old boy, repeated letters going home, do you think it's just a case of stubbornness, discipline failure, or neurodevelopmental condition? Funny enough, this kind of presentation was something that was quite similar to a distant relative who contacted me recently. Exactly this, where over years, the same reports had been coming home, and there had been disagreements between the families about how to approach this. So it's not far from us, it's with us. There are many children like Chidi that pass through your clinic each week. And think about it. If you were the pediatrician seeing this child with these concerns, what would you be doing? Just think about what would you be doing if you were the pediatrician thinking about this? What would you do? So, how many children are correctly identified in your clinic? So we have some figures, and the figures for Africa and Nigeria is very similar to the national figures, to the global figures. Roughly, it's thought about 5% of children will have ADHD. Sometimes it differs by a few percentage. There were studies by Ayano et al. Who had looked at a systematic review. It's about 7.47%. In the past, we've had prevalence studies ranging from 5.4 to 8.7. So you can see hovering around that 5 to 8%. So we can now, if we look at our population and look at the number of children in Nigeria, we are under recognizing and not picking them up. Why is that? Why are we not picking them up? Is it because we don't think it's a real problem? ADHD is not a Western problem. It's felt that approximately 1 in 13 Nigerian children are affected, but less than 1 in 10 ever receive a diagnosis. So there's something we're not doing right. Again, diagnosis rate is low. And even here, we still struggle. We still struggle with the fact that not all children are being recognized. We still have problems here, but there's push to try and make sure that more the children get picked up and diagnosed appropriately. So there is also a gap between urban and rural. We know that if you go to the villages and go and tell them about ADHD or a child there, they probably will look at you as if you're dreaming. but because for them it doesn't make any sense what you're saying. But that's where we have the opportunity to reflect and look at what could be happening. When I've looked back at people I know whilst growing up, where we'd labeled them, not doesn't know what he's doing, or can't get himself right, and people that we thought, these people are just difficult. When you understand neurodevelopmental disorders, you look at things from a different perspective. You take a long-term view of that person's profile and trajectory, and it helps you to understand. And it's usually sad when I reflect on people, relatives, people that are close to me, that their trajectory in life could have been different if those conditions had been picked up early and managed appropriately. So it's not a condition that just leaves you. It doesn't go away. So the earlier you pick it up, the better. And that's one of the reasons why I felt that we need to raise this. So what causes ADHD? We know that there's high genetic heritability. It's not a single gene condition. There are several genes that have been found that, when you study the population of the people, the family members of people with ADHD, there are common genes that have been found, and there are more studies going on to those genes. Now we know there's a lot more genetic information out there that provides risk and information about, conditions, and we're seeing that. And we also know about twin studies, that there's a high heritability in twins as well. But we don't also know about the perinatal and early risk factors. And this is where, I was talking about when I was reflecting on my time in Nigeria. So conditions like birth asphyxia, prematurity, sepsis, all these conditions are risk factors for ADHD. And there's a reason why. So in the course of brain development in the third trimester, that's when a lot of our neurons are being laid down, there's myelination. These conditions usually cause disruption in those pathways that go from the prefrontal cortex, where you have a lot of your problems with the symptomatology of ADHD, into the deeper structures. So when you have birth asphyxia, you've got prematurity, they have several modes of disrupting the pathways. So you don't have the dopaminergic pathways forming well, you don't have enough dopamine at the neural junction to help with nerve transmission, you have problems with signaling. Things like neonatal jaundice can directly disrupt the midbrain structures, and you have fibers going from the midbrain to the prefrontal cortex. So there's a whole neurobiology about this condition. It's not behavior, as in, yes, you're seeing the externalizing factor, but there's a reason why the children are behaving the way they are. Children who have struggled and who have experienced trauma, and we know that there are various forms of trauma that children in Nigeria experience, from, neglect, from, being repeatedly traumatized physically. You can have effects on the pathways, your dopaminergic pathways as well. And so these are things that we need to take quite seriously when we are looking at children. Then we have the prenatal exposures. So when we take a history for ADHD, we are basically looking at all these factors that I have brought out. We're looking at the prenatal factors. We know that maternal smoking is not really a big one in Nigeria, but what else are they taking? What concoctions are they taking? There's lots of things out there now that people are recommending for women to take, pregnant women. Are they well nourished? Are those women well nourished? Here we would ask a lot about alcohol consumption, and because we know that there is an effect on alcohol crossing to the brain and damaging the prefrontal cortex, the nerves there. We know about the fact that nutritional deficiencies can also enhanced problems. So if the mother is not eating well, she's taking all these things, then the brain growth for that child will be affected. The neurons will not be laid down properly. There'll be problems with transmission. So when we talk about ADHD, yes, a lot of it we're looking at the prefrontal cortex, which has a lot of the problems with organization, executive function, and all those core symptoms that we tend to find in ADHD. But what we do know is that it's not just singular there. The brain doesn't work like that. The brain sends tracts into different aspects. So you will have in the prefrontal cortex tracts will go into the midbrain area, and that's why sometimes you can get associated symptoms apart from your core symptoms. So it's important for us to know. And also, I mentioned that if you have jaundice and the midbrain structures are damaged, you will have problems with the transmission of those pathways going up to the prefrontal cortex. And when you have disruption of these pathways, you have disruption of the dopaminergic system and the regulatory systems. And so all kinds of things can happen. So what do we tend to see in the brain with ADHD? Sometimes it's reduced in volume and there's delayed maturation. So your typical child with ADHD is usually a third less mature than a neurotypical child. So you might see the child being emotionally immature. There's just about a third below what is expected. And so we as doctors, as family members, we should understand if that child, people will say, oh, he's not behaving his age. Why is he behaving like that? Like a small child, we should understand why that's happening. The structures are sometimes overall smaller on average compared to what it should be. When we go to the neurochemistry of ADHD, there's definite the deficits. You have problems with the dopamine receptors and the signaling. So you have problems with enough dopamine at the end of the neurons to help with transmission across the neurons and help carry the messages to where, do the right thing. So you and I sitting down here, we're listening, we're focusing. Somebody with ADHD will struggle to hold that attention for a significant length of time because that signaling is not strong enough. So it's almost like think about your mobile phone signal. If you're in a conversation and your mobile phone signal drops, you lose that conversation, you lose that message. And so that's the same thing with signaling that occurs. Where there's deficits, the signaling is affected. And so when we go to talk about medications, the medications work by trying to improve the signaling that occurs. So when we hear, oh, he's taking medication for ADHD, it's not just giving him medication to control himself, control the child. It's doing work across the neural pathways. And then we know that they display impulsivity. So there are problems with their executive function. They can't wait. They are very impulsive. They can't think about the consequences of things before doing it. So they think and they go on and do it. And so this is what you are actually getting. So when you look at the nerve junctions in ADHD, in our neurons, in the prefrontal cortex, you have both dopamine and noradrenaline. Those are the two receptors there. And they're both working to get an optimal function, which is, some people call it the Goldilocks balance, is the just right state. Because if it's not sufficient, there's problem. If there's problems with inappropriate connections, then you would see a lot of motor movements, you'd see a lot of disruptions. And for the noradrenaline, it helps with improving your attention. So it strengthens the signal, whereas the other one reduces the noise. So they're all working together at the neural junction to try and just get an optimal function in the way they work. So if it is too little transmission, they get quite distracted, poor impulse control. That's where you get the noise. And if it's optimal, you get a focused child, organized, flexible, and goal directed. If it's too much, then they can get quite anxious and rigid. And that's why when you're treating children, you have to make sure you are not getting them to the state where they become extremely anxious and suppress, they're not themselves. So you have to get a balance even when it is treatment. So we've talked a bit about the girls. We know that the girls are diagnosed usually later because people hardly pick up the girls. The girls have been many times conditioned to behave in a particular way, so they're rarely running around and disruptive and showing externalizing behaviors. But what you tend to get with a lot of girls is more of the inattentive symptoms. So they could be sat quietly in the class and not listening. They're completely away with the fairies, and sometimes they forget, they're disorganized. I've just seen two classical ones in my clinic this morning. And it is quite sad when this happens because it would have been happening as a younger child. Like the second child I saw today, it was really sad because she'd gotten to the stage where she felt she's rubbish, she can't achieve anything. What will she be like when she grows up? So you could see within her, she's already anxious, she's withdrawn, she's not going out with friends. And I had to spend a lot of time talking to her about her own strengths. And, she left feeling that somebody had listened to her, whereas she's gone her whole life with that narrative where she's getting it from her friends, getting it from school that she is stupid, which is sad. And a lot of our children are getting that. So you imagine a child coming home with the reports that they're not supposed to come home with. How many times would parents sit and interrogate that there could be something wrong? More times than not, parents are scolding the child, telling them they've not been reading, and that I've seen that happen in family members as well. So the average age at specialist contact is usually late. We still have lots of children being diagnosed late here. Again, we still have parents here who do not, it takes them a while to actually understand and actually acknowledge that there's a problem. So most times here you would find traditional medicine. Our families will go to traditional medicine. They will go to the prayer house. They will go to patented medicine vendors to try other things. And that's because they just don't want to identify with the fact that, the child may have problems. So we get that. But it's important to note that it doesn't go away and that 50% of children with ADHD continue as adults. And one of the trends I've seen in my clinic is that a lot of families, parents, after their child has been diagnosed and doing better, they then recognize that actually this was their trajectory when they were growing up, and they have actually gone and sought, you know, referrals for their own assessment. We're having more adults now being assessed for ADHD. That's because they've recognized that there were lots of problems when they were growing up, but nobody gave it a name. And like I mentioned to you, I've got family members where, with what I know now, I could see that this has been classic ADHD, which has impacted their life, their families, their marriages, they're being good parents, and they've not been able to, find fulfillment in life. And I look at these people because they're very talented, and I feel that if they had only had that opportunity to have assessment earlier, it would have been a different story for them. It can have very negative effects on career achievement. Children can drop out of school. Children can come out with grades. You see a child that's got a lot of potential, but you're saying, what are they coming up with? It affects their overall well-being and social interaction as well. So if we're thinking about our society, we call it different names. Like I said, children, they're attacked. The families will carry them to the prayer homes to get repeated prayer. But also we have the problems of few people doing the assessments in our in our place, in our country. When I was approached by a recent family friend of a close friend here, I told the person to go look for a pediatrician where they were to do an assessment. And he came back saying they couldn't find anyone. And I tried to see whether I could find anyone in their local area. But it was disheartening to know that they couldn't find somebody. And because this family was at, like I said, crisis point, I had to do the assessment from here remotely. And thank God that child is fine. But this was a family at risk of, family breakdown, separation, divorce. And it had huge implications. This was a child who is now being distressed, but to see how that child has turned around and doing well and the home being happier, I just feel we need to be looking at this more. So I'm sure many of us have seen the questionnaires. You've got it's the DSM-5 we tend to use. You have to look at the inattentive symptoms. You have to have more than six. So most questionnaires that are screening the symptoms and looking at it in different settings. You have to have the symptoms beginning before the age of 12. So that child whom you're seeing, you should be able to trace a developmental history from what was the child like as a younger child, as a baby, as a toddler. Were they very active? So it's not a child that is just coming to you at 11, 12, or 10 and then says, and there was nothing before that. Um, you have to take a very good developmental history. Then you have the hyperactivity impulsive symptoms. This is a child that's on the go all the time. These are the ones that you would see and say, oh, there's something wrong. But the inattentive ones are equally impaired as well. So, in terms of category, we know that if they've got more inattentive symptoms and less hyperactive symptoms, we say they're predominantly inattentive. And there's the ones that could be predominantly hyperactive. This is the child that is over everywhere, accident prone, and they could have both and could be combined, both inattentive and hyperactive impulsive. So you have to think about what is it looking when you're taking your history, find out what was that child like at a younger child age. Was that a child that the parents had to keep their eyes on, look at them all the time, can't take their eyes off them, runs off, you know, that the symptoms must be extreme for the age, not just normal toddler behavior. As pediatricians, we're aware of what we expect as normal behavior. When you see a child that the behavior is over and beyond what is expected, then think there's something wrong. Doesn't listen. Now, in Nigeria, we interpret certain behaviors. So if that child is not listening when being called, I think people would more say that disrespectful. It might be difficult to pick up in attention. The child might get a slap if the child repeatedly doesn't listen. Um, in our religious settings, in church, if you see a child sitting next to you in church or in the mosque, and the child is not sitting still, running around, people will frown and look at that child in an unusual way. What is this child doing? They'll look at the parents. Why can't you control your child? Um, and the problem is in our school setting, it even makes it more difficult to pick up the children because a lot of the classrooms are big and there's so many children. For about a couple of years, I was coming down to Ibadan once a year to teach on the developmental module on the Masters in Child and Adolescent Mental Health course. And I used to go into the schools as part of one of those modules. I used to go into the schools with the students, the master's students. And this was not too long ago. And the classrooms were busy, it was not suitable at all. So to think of how the teacher, I mean, I don't even want to talk about what was happening in those classrooms because the teacher was completely disinterested sometimes. But how is that teacher going to pick up a child with ADHD? So there's all kinds of things. Now, that child who is being, beaten may suppress the hyperactivity at school, but it doesn't mean that that child doesn't have those problems. Now, we're pediatricians, and that's why we have to think about whether there are organic problems that could be explaining the symptoms. So we're not saying every child that comes in immediately they say inattentive, you say it's ADHD. That's why in our history, we need to ask questions. We need to find out, we need to think about, are there medical causes for these problems? Is there illness? Is there anxiety? Is the child got a learning problem? Is the child hearing? It could be something as simple as hearing. Make sure the child has a hearing assessment done. Is the child seeing? Now, this one is interesting because my part two project for my FWACP was picking up children with visual impairment in primary schools in Lagos, in Surulere area. And boy, did I find some interesting things. So I was going into the schools and I was doing vision screening for these children. And I picked up several children who couldn't see the board, who could not see anything. And they were children who were being flogged, being beaten, being called Olodo by the teacher. There were children who were being traumatized, and I had to refer those children to Luth to get further assessment. So think about vision, think about hearing, think about all this other thing. Is that child snoring in sleep? Is that child having obstructive sleep apnea? Think about it, because it could be something like that. Take a good history. Is that child, eating well, Paulo? Especially now in Nigeria, thinking about things are hard. What is causing this child's problem? So it's just a reminder that we should take a good medical history. And what are the red flags? I've put a whole lot here. Think about the child who's got some pre-existing risk factors that could make them at risk for ADHD. Think about a child who is underachieving. Where there's a family history, think about that. Think about a child who's got epilepsy, because there's a high proportion of children, significant, who have neurodevelopmental conditions. So I run epilepsy clinics here, and I always screen for neurodevelopmental conditions because they're quite high. We've talked about the fact that you have to take a good history, because we've talked about why these risk factors from the neonatal follow-up clinic could be signals for, explaining to the families that you need to look at these children's development. So how do you assess them? First of all, you make sure you find out from what is really happening at school, get information from the teacher. And when I did a remote assessment, I was able to get questionnaires completed by the teachers here in Lagos, for children, in Port Harcourt for children. So it can be done. Those teachers can provide information. We just need to look at the information, make sure that we are interrogating it within our own communities. Rating scales. Look at the rating scales that have been developed. We need to be mindful that a lot of it has been developed in the Western society, so we should think about the questionnaires we use. I have questionnaires that have been adapted that I use when I'm seeing children from Nigeria, using the same DSM-5 questions, but helps me to get information that is more culturally relevant. And then the informant may be the parent or caregiver, find out about the home, what's really happening, what's happening with that child. The class teacher contributes. If the child is able to talk and give a history, get for information from them. Sometimes it might be aunties, it might be grandparents, other members of extended family might be able to get that information. So we need to be aware about the fact that don't just look at one section, get information. And think about the fact that if a child is not really hyperactive, is that child very anxious? Is he afraid? So because they might be suppressing hyperactivity as well. There are several free rating scales. Vanderbilt is readily available. You've got the teachers and the parents. You've got SNAP, which is available. SDQ is available. Corners, you need a license, but you need a license and you need to know how to use it. But now we're having online corners where you can, if parents have the ability to complete online questionnaires, then there are online corners as well. So we've talked about information that we should get. We've already talked about antenatal medical information from school and family structure. When you see the child, make sure you do a clinical examination. You do a thorough head-to-toe examination. You do a neurological examination. That forms a lot of what we do for every child. You've not assessed the child well until you've actually done all these things, you know, check whether there are any distinctive facial features, because the child could have a genetic condition. And we know that there are lots of genetic conditions that present with that ADHD is a comorbidity. Look at the mouth, as we said, ask about sleep, nasal obstruction, ask about vision and hearing. You make sure you are checking all that before you think about ADHD. And if needed, um, you can request for investigations and avoid, we don't do routine genetics or MRI except it's necessary. Now, ADHD, what we call vanilla flavor ADHD, that's ADHD on its own, is with the number of children we see with just ADHD coming and nothing else are quite small. We tend to see them coming with a lot of other things, anxiety, learning problems, defiance, autism. We see a lot of that. So when you're taking your history, make sure you're screening for other things, because just a child coming with pure ADHD is rare. So when you've gathered all this information, then you can take your guidelines and look at it. Is this child meeting that? Have I done a proper developmental history? Have I examined the child? Have I met does information from school and parents correlate? What am I seeing in the clinic? Then you look at your DSM-5 criteria. You decide whether the child meets it or not. You decide whether there are other comorbidities, and you decide whether there is impairment. So ADHD is not just anybody that has inattention and all that you diagnose with ADHD. There has to be what we call functional impairment. So there's some people that are hyperactive, they can be moving around, they're not impaired, they're doing very well. But impairment refers to, is it affecting his academic performance? Are things impacting on the child in such a way that they're not achieving as well as they should, their potential? Is it affecting peer relationship and family functioning? Is it affecting their own self-esteem? Like the girl I saw today, she was heavily impaired. And what is the family's understanding of this? Because they have to make a change. They have to make a change. So the first thing you do after diagnosis is you need to educate the family, explain to them what is happening. Let them understand that this condition is not because the child is choosing to be naughty. You can have a picture of the brain. I use pictures a lot to show the families in the clinic, show them what is happening in the language they can understand, and explain to them that actually them maltreating the child or beating the child or expecting things to just go away will not happen. Then you have to think about how you convey that information to the school as well. You also need to inform parents about what can they do. Now they know how this child, ADHD is just the way the child's brain works. The child has lots of strengths, and a lot of my children with ADHD have amazing strengths, amazing, potential, and some of them do things that have blown me away. So explain to the families that they should understand, so that they can understand how can they support this child, what can they do, and that's a whole behavior training bit. The mental health gap has looked at the impact of behavioral training on ADHD, and they've said there is some benefit in actually, training parents and in improving the outcome for the child. I know that it can be difficult in our Nigerian setting. How do the parents access that? That's something like a project somebody might want to do. Um, but think about it. So medication is not usually the first line, but if things persist for a long time without improvement, then we go to medication. And there's a problem with medication is that, again, that's difficult to get, access in Nigeria, which a lot of the families I see have mentioned. So you tell them it's brain-based. It's not caused by witchcraft, spoiling, or poor home training. It's not that the child is choosing to be different. And there are benefits if the child needs treatment or approaches to treatment, that child can do very well. And you begin to explain to the parents why. And you have to think about fathers explicitly, because what I've found out in some of our families is that obviously the fathers who, sometimes decide they don't believe it. It is difficult for the mothers to then apply those strategies or follow through. Then you have to also think about the grandparents as well. Think about external family. There's a family that I know where, immediately the child was given a diagnosis, the grandparents said, no, that's nothing, it's not here. And even when the child was being treated, the child would either have treatment in one place or the other. I'm seeing that I have to run now. I have to rush off now in terms of speed up the presentation. So think about the, behaviors, and then train external family members about supporting the child. Um, in the classroom, what advice can you give? I've put some of that here on the slides. And in terms of medication, now maybe you can give me an up to date, but from the families I've dealt with, it's been very difficult for them getting medication. Some of them have to wait till they come here to pick up prescriptions. It's been so difficult. And I feel that this is something that we should look at as pediatricians in Nigeria. Why is this not available? Why are children struggling with that? We talked about medication. Medication works because what is happening is we've talked about noradrenaline and dopamine being at the ends. They're going into the neurons and they're being recycled back into the synapses. So what happens is when the neurotransmitters, noradrenaline and dopamine, are taken up too quickly into the neurons, then you don't have enough at the synapse for things to work. And so your medication, what it's doing, it's blocking the reuptake of those neurotransmitters, therefore allowing enough to be at the synapse, therefore binding to the postsynaptic receptor and improving signaling and improving transmission. And then you see the core symptoms of ADHD being improved. So there's a science with the way the brain works. And then other medications like atomoxin and guanfacine. I won't go into this a lot. What do we do when we're starting medication? Start very slow. Make sure you plot the weight and height. Make sure you take a cardiac history. And if that child's got a family history of cardiac problems, maybe sudden death in a young family member, first degree relative, make sure that child has a cardiac screen before you do. There are cardiac implications for this medication. So please, when you're taking your history, you don't need to screen every child for cardiac problems, but when you're taking a history, please do. So I think I'll have to end there because I look at the time and I know there'll be questions, but there are case histories here as well. And like I said, I did a remote assessment and we successfully did that. So in ending, ADHD take-home message is that it is common. We are seeing a lot of the children that are coming into our clinics, be it neonatal, be it cardiology, be it neurology, whatever discipline we're seeing, we are seeing children who are at risk of having long-term neurodevelopmental problems. And so it's on us to look at the holistic picture of the child. We shouldn't just say, oh, we've treated the acute condition, off you go. We should think about the long-term, you know, um, of that child. And if that child has risk factors, let's let the parents know at the time of discharge that because of what the child has suffered, they are at risk of getting ADHD. And they should look for it. They should look out for it. What should they do? We're not saying diagnose them now, but we're saying that they're at risk and you should think about it. So I'm going to end here because I need to leave time for questions. But I hope that I've been able to just help us go through why I started doing this, why I'm passionate about doing this, and I've been able to interview two people from Nigeria, two educationists in Nigeria on my podcast who are doing some work on, trying to educate the public, trying to provide support for the public, for children with neurodiversity. And the problem that they keep mentioning is there's no place to send them for assessments. The families are struggling. And the last one I interviewed was really painful because she was naming places on the island And I was thinking, how many people can afford to go there to get this assessment? So the majority of children are still being, undiagnosed. So thank you very much for the platform. Thank you. And I'm looking forward to hearing and, seeing that many more of our pediatricians are, seeing children and doing the assessments, and that we're working to see how to get medication, more accessible in Nigeria. Thank you.
Thank you very much, Dr. Takon. That was ADHD in a nutshell. Concise, concentrated, it had everything. I just wish I was in your trust because this made it even clearer. And I know there are several people who have questions running through their minds. I see there's one or two questions on the chat. If you have questions, kindly drop them on the chat. I will read the first one for your comment. So this is Motala Ahmad saying, thanks for simplifying the discussion on ADHD. What do you have to say about the concept of primary/typical ADHD and children with secondary hyperactivity symptoms from later brain insults, including their treatment approach? That's the first question.
Thank you, Mutala. That's a very good question. And yes, that does happen. We just qualified that when the child's got ADHD. So let's remember that ADHD is a descriptor, is describing symptoms. ADHD is describing a cohort of symptoms. Our job as clinicians is to understand why is this thing happening. So yes, children can have ADHD symptomatology secondary to trauma, secondary to so many things. We've seen very difficult to treat epilepsy. The child then presents with ADHD behaviors. Once you've got the pattern and you can pick up the underlying cause, if you've got a profile that fits that and is presenting at home and at school, even though that child, yes, did not have the early developmental ones is the one that we tend to know and call the primary ones, but you can still say that child's got an ADHD profile, but qualify what the reason is, and you can still treat the child. So we've got children like that in our service where there's been a reason for them having those symptomatology. And I'm stressing that when we say ADHD, it's a collection of symptoms. You describing inattention, hyperactivity, impulsivity is not telling you what the cause is. And that's where you as pediatricians, me as pediatrician, that's our job in delving into it. But if we get a profile that fits and we know, yes, we want to help that child because the aim is to get that child more functional. And you can have trauma that can disrupt those pathways. You can have trauma, accident trauma. So sometimes I review reports for children who've been involved in traumatic brain injuries. And you can have that trauma affecting that part of the brain, and they can present with ADHD symptomatology. So yes, thank you for that question. It was very good.
Thank you. There's another question, and Ojuku Chisom Chiwendo is asking, what can be done to make the drugs available in our country and also at affordable prices?
I think this is something that the country needs to take up, and we need Pediatric Association to make a case for this, um, shout for this. We've got this problem, and I think we can work together with the local resources, the local ministries, to see the basic medication. Because so what usually makes me sad is to see children who can be treated with simple methylphenidate now being treated with antipsychotics, risperidone, and all those heavy drugs because that's what's available. We shouldn't be doing that. Methylphenidate is so, it's so easy in terms of using to treat, and then you've got the flexibility. We shouldn't be giving children such heavy doses of things that then causes metabolic problems. You've got to keep monitoring things and can tip some of them to quite serious side effects. So this is a call to action for PAN and Neurology Association. Please, please advocate for these children.
Okay. Thank you very much. There are lots of people saying thank you. I
Sorry.
think we've run out of time.
There's some. So there are two senior colleagues that their hands are up. Professor Grange and Professor Abiodun. I would think we should allow them to just speak to what they have to say. Thank you.
Apologies, I didn't see their hands. Please go ahead, Dr. Grange. Thank you, ma'am.
Thank you very much. First, let me thank Dr. Takun for that brilliant presentation. Dr. Takun, I suppose you recognize that I was one of your senior colleagues in Luth.
Definitely, Ma. It's lovely to see you, Ma. Thank you so much,
and I remember you as being very dedicated, and really I'm not surprised that you chose this this line of pediatrics, because it does require a lot of patience and dedication. And thank you very much for letting us know that. Now, I could talk to you. I think I'll talk to you later, by one-on-one. But one thing is this, that unfortunately, because we have failed to realize that there are children like this who need support right from childhood, from birth, to become functional, brain-wise. They grow up into adulthood and they actually manage to scrape through to, responsible positions, and they are not able to handle those positions, you know. So it's a very, very important area for us all to look at. I'm sure that 50% of politicians today had ADHD, and they were not picked up. Seriously, I'm serious about this. Look at them. And I hope that, we'll be able to get together and look at how we can screen these people. So in all fairness, there is a lot to be done for these children. The unfortunate thing is that the family itself does not recognize this. And when they do, they are in denial, and so nothing effective is done about the children. And then one of the parents may actually also have adult ADHD, and that compounds the whole problem. Thank you very much, Dr. Takon. I would love to talk to you one-on-one after this. Thank you.
Thank you, Ma. Thank you, Ma. Surely will do. And you've raised a very, very important point. So there are some children where they coast through by virtue of their intellect. They're managing to coast through. But if you look at them, they're still not achieving their potential, but they're coasting through. So they pass, they're moving on, they're moving on. But what you find is when they get to the point where those demands on them are larger than what they can cope with, they just decompensate. So I've had families where their children, they've known that there was problems, and their children have come over to the UK to school, and it's a problem they've known, but they've been denying it or not wanting to confront it. And some of those children have had to drop out of uni, despite all that has been put in for them, because the child just hasn't been able to cope, because all the scaffolds that the parents were putting in is now dropped. So they are now having to leave on their own, do the academic work, whereas at home they would have been having their parents on their case, making sure. But the minute that they have to do it on their own, all those scaffolds drop. and they struggle to keep up. They're not going, nobody's pushing them. They're in school, they're in uni, and then they kick them out. And when you look at it, a lot of parents scaffold the child until the point where it gets where the child has got to face it and they struggle. So yes, it's a very well recognized situation.
Thank you.
Thank you. Okay, I think we have Dr. Abiodun's hands up.
Dr. Abiodun, please.
Thank you very much, Dr. Young. Well, I would agree. I think the politician you are talking about is not the Adhd. They are only drug induced, the drugs they take. So now, Dr. Young, now what do you say? How do you differentiate this one from autism? Because I believe in some cases, some behaviors of some of these children, you will still wonder whether it's ADHD or autism. Can you please tell me how to really differentiate them? Number two, you seem to be so optimistic about this drug therapy. Is the prognosis really so good with the drugs you give them? Thank you.
Thank you, sir. Thank you, Prof. Yes, so we find a lot of children sometimes have both. So there's a high prevalence of children with ADHD who may also have autism, but there are strict ways in assessing autism. That's another big lecture, and we can talk about how to differentiate ADHD from autism. But you have to use these tools to assess them properly to be able to see whether they meet the criteria. And we have a lot of them in our clinics, both ADHD and autism. The medications work. So I've been running my service now for over 20 years. And I can tell you, one of the joys I have with treating children with ADHD, they're the most rewarding children to treat, because you see children where they started off, no hope, people didn't know where they were. I've had several of them hold on jobs, finish university, doing very well, doing really well with the medication. Some of them tried stopping the medication for a while. It depends on the work they're doing. It always depends. Medication treatment is an individual thing. You have to think. Some people would say, okay, I've taken it for this time, let me stop it. But they realize that they can't function well. I mean, I'll tell you one child I saw once where the father is a lecturer in Cambridge, and he had always struggled himself. People never believed him because they thought, how can you, a lecturer in Cambridge, be struggling? So when I was treating the son did very well. And I would never forget, this man one day wept in the clinic. And when I asked and I said, what's happening? He said, he's been trying to tell people about his struggles, but people look at him and say, you're a lecturer in Cambridge. How can you have ADHD? And so I signposted him to an adult who saw him, who treated him, and the story was different. So it can be a huge functional impairment. You can see people sitting and smiling and looking fine. They're not fine inside. They know their struggles. So it's just to let us know. Medications work, and they work very well, but they're different medications, and that's why we have to look at different ones for different people.
Thank you very much.
Thank you.
Do we have time for more questions, Dr. Dushote?
I think we are almost run out of time.
Okay, there is a hand up.
Okay,
yeah,
let me.
Can we give 5 more minutes?
Okay, so we can ask Dr. Ismail Olabisi to please go.
30 seconds.
Dr. Olabisi, please unmute and just speak, please. Well, okay, I guess. Okay, I guess there's Dr. Joy. Dr. Joy, can you please unmute and speak, please?
Yes, sir. Thank you very much, sir. Thank you, Dr. Takon, for a wonderful presentation. So in my practice, I've noticed that most of the children with autism and hyperactivity don't respond well to methylphenidates. And I wondered what your experience has been. And then sometimes we have to give risperidone. Recently, I came across aripiprazole. So I just wanted to get your take on some of those medications and which
What's the name of that drug? For that drug? You said the last one you called?
aripiprazole.
It's just like risperidone.
Yes. So what do you usually use with children who have the comorbidity of autism? with hyperactivity. The methylphenidate doesn't seem to control the hyperactivity in a lot of them. I don't know what your experience is, ma. Thank you, ma.
All right, thank you, Joy. So the guidelines states that yes, you should use methylphenidate as first line. And we know that children with autism can be very sensitive to methylphenidate. So you start very low, start with a very low dose, and then do very slow titration. If they are still not, tolerating it, you go to a non-stimulant. Non-stimulants like atomoxetine or even clonidine. I must tell you, we don't use risperidone and aripiprazole. They're antipsychotics. We don't like using them because of the side effects. Yes, they can look like they're calming the child down and all that, but I think when we're treating, we always have to think about the long-term effects of these medications because they've got metabolic effects. We've seen children tipped into diabetes and all that. If there are, in fact, before any child is started on those drugs, they have to be seen by psychiatrists where we are, where I am. Maybe there are other places in the UK that are using the drugs. It's just, where there are other options. There is clonidine. If we can't get atomoxetine, we can use clonidine. And there is guanfacine. I know that might be difficult to get, but atomoxetine is another medication that can be used. These are all recognized, cleaner medications for treating ADHD.
Thank you very much. So I'll yield to our President, Dr. Letu, to please just do the honors, and then we'll wrap up. Okay, well, I have to indulge my sister. Bumilosin, please go ahead and talk. You are my friend. I can't.
Thank you very much, Kaide. And at the risk of drawing us back, Ian, what is your take on the relationship with substance misuse? Because I often come across a lot of young people who what they're doing really is self-medicating on cannabis.
Yeah. So if we think about the brain and the pathways, what is happening? You remember, I'm talking about the dopaminergic pathway, and you need more dopamine for signaling. A lot of the substances are mimicking those pathways, but they're getting just a temporary hit from there. That's why they take it. So it's actually trying to mimic what is
self-medicating, really.
yeah, that's why they self-medicate. And it's also going to their reward center. In the nucleus accumbens is going there. So they get a temporary relief, but they get a big crash and it doesn't last. And so, yes, that's why when you see a child, when you see a young person who is misusing substance and hasn't been assessed and diagnosed with ADHD, think very well. That child probably has ADHD. Get them assessed. Get them
Absolutely.
treated.
Yeah, thank you very much for that. I thought that was an important point to bring out. Thank you.
Thank you very much. Dr. Letu, please, over to you.
Okay, thank you very much, Dr. Takon. Well, before I comment further, just to let Dr. Lawson know that being the last person to ask a question, be the next presenter. So please get ready for next month. So, Ian, thank you very much for the wonderful session we've had this afternoon. Even though it's a holiday in Nigeria, we had more than 100 people, and we had another 37 people who joined on YouTube directly. So obviously, this is one of the lectures that has given us the largest or the highest volume of attendees. So it means you've done a very good job. Like I said, we ambushed you this time around. Be rest assured, I've told you sometime next year, we'll give you some readings. Maybe this time we'll be talking about autism, because that seems to be something else that we're seeing a lot. In fact, in the last 1 month, I've seen 4 children with autism, surprisingly. And I'm wondering, are we now having an epidemic going on?
Yeah,
we now know that to look for it, and then we're seeing them. So thank you very much. I want to thank everybody again who sacrificed their public holiday to attend this meeting. It's been rewarding and it's been educative. And I hope that next month we'll have such a large turnout again. Also to thank Professor Grinch, as usual, for attending. And Dr. Mobolaji Lawal, Professor Abiodun, our seniors who have attended this program. And we look forward to seeing all of you again next month. Thank you very much. I yield back to Dr. Dushote.
Well, thank you very much for everyone attending. Ali, you're clearly to have thanked everyone. Just to let you know that Dr. Afiom also is a very good friend of mine, a junior sister, and she's working in that space. I'm sure if you want contact with Dr. Khan, you have to say to me, as they say in Nigeria. But this recording will be on their channel. We have a channel where we'll put this recording, where you can actually listen afterwards. And I'm sure if there are questions, we can actually reach out to Dr. Takon to answer those questions. And I'm sure the journey still continues. And I'm sure because I have a relation we have way back from Ibadan, I can get her to come and do some modules also for us physically. So I want to thank everyone for joining this meeting. So we're looking for a very fruitful, useful meeting next month. For the rest of us, at least in this part of the world that's on holiday, so enjoy the rest of your holiday. And then, like I said, I'll continue to pepper you as Arsenal fan until we win the Champions League. God bless you all.
Thank you so much.
Thank you very much.
Thank you.
Dr. Lawson, Dr. Lawson, next month, I'll be on your case, don't worry.
Thank you.
Ian,
Dr.
thank you
Takon,
so
when are you
much.
going?